Hello everyone, I am Dr. Naufal, specialized in physical medicine rehabilitation, a physiatrist. Here we will discuss about basics of ultrasound machine for use in botulinum and toxin injections, mainly for spasticity and dystonia. Postulate that you have a very basic idea of ultrasound, so you will just have a glimpse through the basics, and there is no conflict of interest from my side. The learning objective will be to understand the basics of ultrasound for botulinum and toxin injection. We know ultrasound is to improve accuracy during injections and to avoid complications. We can identify the vessels and avoid them. So ultrasound is used because we can visualize the target muscles correctly and avoid the other structures like nerves and blood vessels. And some areas where the muscles are having fibrosis or contracture, there will be hyperechogenicity, very uh, contrasting hyperechogenicity, and we can avoid that area because it might not improve with botulinum toxin injection as it is indicated in spasticity and dystonia. So the frequency of the ultrasound probe, the diagnostic ultrasound is usually 2 to 15 megahertz as opposed to the therapeutic ultrasound being used in physiotherapy as shown in the figure, which is having a frequency of 0.8 to 3. So this is having higher frequency. And the scanning technique is very important. When you hold the probe, you always hold it like a pen between thumb and fingers of the dominant hand. And the transducer can be stabilized on the patient skin with the heel of the imaging hand. So if you keep the heel of the imaging hand here, the transducer can be stabilized on the skin of the patient. Ergonomics: to minimize fatigue, we have to make sure that the scanning hand is lower than the shoulder, and chair should have a good back support and preferably with wheels so that we can mobilize ourselves freely. As an international dictum, the proximal aspect is usually kept on the left side of the image. So it's all about common sense. So how we are comfortable, just see. Usually proximal aspect on the left side of the image and distal aspect on the right. But some physicians have their own ways of keeping the probe. But make sure that you're not getting confused. So these are the main settings, minimum settings that we have to know in the ultrasound: focus, gain, and depth. Focus is basically focusing on the exact structure. Gain is increasing or reducing the ultrasound beam. So basically, when the ultrasound wave goes to the body and comes back, it gets reflected back. So we can increase or reduce the beam. So as it's shown in this image, so this is A, we are just getting an image. In B, we correct the depth. We make sure that the area of interest is in the center of the image. And C, here, the focal zone, if you see on the side, the focal zone is actually adjusted to the site of the injection. And then D, gain. Gain means we are increasing the gain of the ultrasound coming back to us so that we can see it more clearly. It becomes more bright. So we have to adjust. It should not be beyond a limit, because if the gain is too much, it will be difficult to differentiate from the remaining structures. So coming to sonographic appearance of normal structures, if you keep the ultrasound anywhere in your limbs, usually over the muscles, there will be a small layer of ultrasound gel and then epidermis dermis. It is a very small layer of skin. And then subcutaneous fat will be there. It will be different in different individuals. The width will be different. And then you have the muscle layers, and in between we can see fascia also. So when we look at tendons, so many a times we send the tendons around the muscle. It will be broom-like, like a broom. Like this is flexor digitorum superficialis, flexor digitorum profundus in the forearm. So you can see these are tendons, very tightly packed fibers. It's like a broom. And here muscles are little bit free. You can see like a starry sky appearance. Muscles are having good bulk, and it will be the muscle fibers are dispersed when compared to tendons. Coming to nerve, this is carpal tunnel. Inside the carpal tunnel, we have the median nerve. It's having a honeycomb appearance. If you see here, the tendons are there all around, which are broom-like, and this is honeycomb-like. So there are two techniques to inject. One is in plane and out of plane. So in plane is usually preferred in the beginning for people to understand it easily. So we'll keep the probe and the needle will be passed parallel to the probe at exact center of the probe. So we need some practice for this, but it's rather easy than out of plane in the beginning. So when we go out of the plane, the probe will be in one direction and the needle will be in a perpendicular direction. So when the needle goes inside, when it reaches the center of the probe, you can see the dot. But when it crosses also, there can be the dot. So the important thing is you have to take the needle inside and see the machine, whether you can see the dot. At the first point when you see the dot, it will be in the center. So if you miss that point, you might actually be going inside, but you will be seeing the dot and you might be injecting somewhere else. But after some time, out of plane becomes easier than in plane usually. So this is another image showing in plane and out of plane. Out of plane takes lesser time when compared to in plane. Thank you.